Welcome to National Emergency Life Support course for Paramedics. I am Dr. Tej Prakash. In this particular talk, we are going to discuss about traumatic emergencies or emergencies with trauma. So, we will try to understand how we are approaching these trauma patients once we meet, how we assess and manage the exsanguinating hemorrhage or life-threatening hemorrhage in a timely manner. What is primary survey, how to do it, and what kind of managements we will take during doing this primary survey. And finally, caring en route, so safe transfer and handing over properly to the hospital wherever we are taking these patients. So let's have a case scenario. So a 45-year-old man who was having no protective gears or non-restraint got ejected from his car and found lying on the road following one motor vehicle crash hit from behind. So he has sustained lower extremity trauma, which is bleeding, and the lower limb was amputated. So there was a bleeding from the amputated right limb, multiple abrasions over the interior chest. Presently, he is conscious, alert, and asking or crying for help. He has not got any kind of treatment till you reach there. So just remember this way of reading a case scenario, we call it as missed format. So we understood the mechanism M. So mechanism was road traffic crash, got ejected, hit from back and found lying on the road. Injury pattern, he is having lower extremity trauma with bleeding, multiple abrasion over the chest, and the signs we got, he is still conscious, crying for help, alert, and no treatment. So this is the missed format or missed format of information. So as you reach there as a pre-hospital care provider, you are asked to rescue the patient from the scene, and how you are going to approach this patient, what will be your priority in assessing this patient and managing this patient. So let's take the brief snapshot that what we are going to do. So quick assessment at scene and doing something at scene. So quick primary survey, then going for resuscitation, going for critical interventions, maybe something at scene, something inside the ambulance that is en route, and finally understanding the concept of triage. So triaging this patient sick, not that sick, very sick, red, yellow, green, that kind of triage, and initiating the safe transport and handing over finally to the hospital. So these are the brief steps we are going to take. So let's take the things one by one. Safety. So always remember that whenever you are approaching this injured victim, there is high likely that you will meet with blood, vomitus and all. So universal precaution is always important. Coming to safety, you must remember you have to save 1, 2, 3. One is you, the provider. Second is whether the scene is safe to intervene, yes or no, and your patient or victim should also be taken care for safety. The first and foremost idea is controlling life-threatening bleeding. We call it as exsanguinating bleeding. Okay, so when you approach this patient, you have to take this patient to safer side, stabilize the neck, put a cervical collar, put on a spine board, strap, immobilize the head, and shift inside the ambulance. So let's see how we are approaching this patient in form of primary survey. So primary survey we called is ABCD, and we added one more thing to it, what we call as XABCD. X is for exsanguinating hemorrhage, and always remember reassessment is the key. It is not one time job that you have done ABCD once, it is done. So always the idea is to identify and treat or deal the immediate life threatening conditions in the right sequence. So these are the XABCD, exsanguinating hemorrhage control, airway management, and same time while you are managing in trauma victim the airway, you should take care of cervical spine stabilization. So B is for breathing, that means the ventilation and oxygenation need to be maintained, assessed and maintained. Circulation, so you assess the circulation, look for hemorrhage and maintain the perfusion and control the hemorrhage. D is for disability, that means the brain function. So here we will go for neurological assessment or brain function assessment. So ABPU or GCS, then going for pupil assessment, so and focal neurological deficit. E for exposure and hypothermia prevention. So these are the ABCDE approach to trauma patient. Now coming to very important is controlling exsanguinating hemorrhage or important hemorrhage. So this can be done by direct pressure. Sometimes we have the things to do, the dressings or other things, so we can pack the wound if it is coming from deeper one. And very handy and very important life saving is the tourniquets we use, especially for the extremities. Like you can see in the pictures, we have utilized one tourniquet, that is the Foley catheter. You can utilize proper tourniquets. For suspected pelvic fractures, we use pelvic binders to control the hemorrhage. So you can see the tourniquets, the various kind of tourniquets. So one kind of tourniquet, this cat tourniquet or the combat action tourniquets. So these are though costly but very effective. The pelvic binders, we can use the bed sheets or the clothes for making the pelvic binder. This is very important to utilize this, because the pelvic bleed can lead to deaths. So hemorrhage control or bleeding control. Now coming to ABCD part. So quick assessment of patient can be done in 10 seconds. So 10-second primary assessment is just by asking the name. You can know whether the ABCD is fine, yes or no. You just ask his name. Hello, what is your name? क्या हो गया आपको? What has happened? So if he speaks his name correctly and tell the happening, or just telling the name correctly, that means he can vocalize, his airway is patent because he is speaking. If he is having enough reserve in the chest, then only he can speak. So B is also fine, and he cannot speak the things properly or understand the things properly until unless the brain is functioning. But the brain functions when you have good circulation, oxygen supply is good and glucose supply is good. That means C is also good, D is also good. So if you just ask some person his name, and if he is able to speak his name properly, you can understand that at this particular moment his ABCD is fine. But always remember, they may deteriorate. So reassessment is key. So this is a quick way of primary survey or quick way of primary assessment. Now coming to the detailed one, you have to go for detailed assessment of ABCD and management accordingly. So let's go with A, airway. See, always remember that the cervical spine immobilization or motion restriction is taken at a very high priority along with the airway. So always remember, in trauma we take cervical spine is injured until proven otherwise. So always maintain inline stabilization of cervical spine and put the cervical collar. So manual inline stabilization of neck, application of cervical collar, assessing for airway in a very simple way of look, listen and feel. So we look for whether the airway is patent, yes or no. So if you can see obvious airway injury, there is some foreign body, or you are listening that the voice has changed, noisy breathing, gurgling sound, stridor, this all says that airway is threatened, some problem is there. If a person is having low GCS, again high chance that his tongue will fall, so airway will be threatened. So oral bleed is happening, then airway is threatened. So this is how we know airway is normal or abnormal on look, listen, and what you can feel also is feeling for any swelling or crepitus. Swelling or crepitus. Okay, so that also says that there is some injury to the airway. You can just have a look that patient is having maxillofacial injury, which is quite visible, may not be visible, but you palpate. If you palpate, if you have bony crepitus, you can think that the patient is having maxillofacial injury. So look, listen and feel. You just look for whether the airway is patent or threatened or obstructed. If obstructed or threatened, you have to do the action. Now, overall idea is to maintain the airway. So, for maintaining the airway, we can have simple maneuvers like jaw thrust. If you have any secretion inside, blood or secretion, you can go for suctioning. Always give oxygen to these patients, because many times these patients are agitated, not due to head injury but due to hypoxia. So, always give high flow oxygen, 11 to 12 liter per minute, and if required, you have to establish a definitive airway in form of orotracheal intubation. But in pre-hospital care, we can keep on suctioning, maintaining the open airway by jaw thrust or just by chin lift, and we can put OPA for tongue fall prevention, or if required, we can put laryngeal mask airways or LMAs. Those who are trained in orotracheal intubation, they can go ahead with orotracheal intubation. Sometimes we have a situation which we call as can't intubate, can't ventilate. Then in those situations, we can go for surgical airway, that is cricothyrotomy, maybe a needle cricothyrotomy followed by open cricothyrotomy. So, this is how we manage the airway. Now, coming to the breathing and ventilation part, again you have to expose the whole neck and chest area so that you can assess properly. Again, look, listen and feel. So, look for the rate and depth of respiration, whether the chest wall is moving properly, yes or no, any open chest wound, any abrasion, laceration is there, yes or no, whether the patient is using accessory muscles, yes or no. You can go for auscultation, listening for the breathe sound on both the sides, feel whether there is dullness or you feel any crepitus. So, these are the findings which will tell that breathing is having some kind of problem. So, managing the breathing, if you have open chest wound, you can go for 3-side dressing. Always remember that these patients will require oxygen. You have checked the respiratory rate, saturation. These things also is evaluated along with the clinical look, listen, feel. So, always administer high flow oxygen, 11 liter per minute. Monitor saturation, keep the saturation more than 94%. If required, go for bag mask ventilation. If you are suspecting tension pneumothorax, that means breathe sound is absent on one side and saturation is falling, BP is falling, then think that this patient is having tension pneumothorax. Go for needle thoracocentesis followed by chest tube insertion. Open chest dressing, open chest wound, we have to go for 3-side dressing. And finally, you have to take this patient to a place where he can be treated as early as possible, ideally within the golden hour. Coming to circulation with hemorrhage control, so always remember, if you see blood loss, you have to look for the floor, that is the external bleeding, or 4 other places, like the bleeding can happen inside the chest, inside the abdomen. There may be a pelvic fracture or some retroperitoneal space can have the bleeding. Sometime in long bone fracture, the blood can be lost into the muscle compartment. So, these are the areas where you should be looking for breathing. Once you identify the source of bleeding, you have to control the source of the bleeding. So, assessment of circulation can be done by the other measures or monitoring measures like the heart rate, blood pressure and capillary refill time. So, ideally the normal capillary refill time is less than 2 seconds. If it is more than 2 seconds, you suspect there is some hemorrhage ongoing. So, circulation is at stake and you have to manage accordingly. So, how we manage external bleeding? We have already spoke about. So, pressure, bandage or maybe tourniquet if required. Okay. And we give pre-warm ringer lactate as IV fluid. So, you have to put 2 large bowl IV cannulas, that is the 16 gauge gray cannulas. Give pre-warm ringer lactate fast. Any fracture is there, you have to splint that fracture, and one drug is used which is very effective, must remember, must keep, is tranexamic acid injections. So, in those patients who are in shock, injury time is less than 3 hours, we go for giving tranexamic acid. So, we give 1 gram IV mixed in 100 ml normal saline, we give over 10 minutes. So that is the loading dose, and we continue with the same amount over next 8 hours. So always remember, while doing this, these patients are quite hypothermic, may not be externally but internally. So always prevent hypothermia in these patients, otherwise they can initiate the cascade of death. Coming to disability part, so we spoke about a very simple way to assess the brain function, that is the ABPU, whether the patient is alert, responding to verbal stimuli or painful stimuli, or unresponsive. But ideally we should be practicing the Glasgow Coma Scale, that is the GCS, which is having 3 components: the eye opening, the verbal response and the motor response. And these are having the scores from 1 to 4, that is the eye opening, 1 to 5 is the verbal response, and 1 to 6 is the motor response. 3 is the minimum, 15 is the maximum. So apart from GCS, we go for checking the pupil for size and reaction and looking for any focal neurological deficit present, yes or no. So this is how we assess the D part or disability part. So it is very important to undress the patient, so expose the patient so that you should not be missing any injury, and same time protecting the patient from the hypothermia. And must remember that dignity is very important to maintain. So must be taking care of the patient privacy at the same time. And remember, the AVPU is very simple way assess the disability part. So now safe transfer and in route care, safe transfer and handing over at the hospital. So always remember that while you are transporting the patient, applying the on board, it is good time to log roll the patient and examine the back also. So document all the activities you did, all the findings you have, and give a proper handover in form of SBAR, which must include the MIS, that is the mechanism, the injuries, the signs, and the things which has happened or any treatment given. Communication is key. Always remember that good communication is key with the patient, relatives, the command center, the next hospital, and among the healthcare providers. Right patients taken to right place in right time can save lot of life, and we are living in era of golden hour. So must remember, time is key and right set of management, assessment and management is key. So just to summarize, always remember the scene safety and control the exsanguinating hemorrhage whenever you met with these kind of patients. Safe shifting on a spine board, taking care of neck, manual inline stabilization, log rolling, which is very important. We have understood about the primary survey, that is the XABCD, or sometimes we call it as CABCD. So X exsanguinating hemorrhage, documentation, which include the MIS protocol, communicating with all, giving proper handover is very important. These are my references. Thank you.